Hi, I'm Chirag Patil. I'm an associate professor of neurosurgery at Cedars-Sinai Medical Center, and I'm going to be talking to you about pineal cysts today. Looks like we have a great turnout for this webinar, so welcome and thank you for joining me. So the story really starts when a young woman came to me and asked me, is my headache coming from my soul? And I was taken aback. I was like, huh, what are you talking about? And so, this woman turns out she's 22 years old and she had these severe frontal headaches. Okay. And turns out that she's a philosophy major. And so she told me Rene Descartes, the seat of the soul. So, as some of you know, the pineal gland was supposed to be, was thought to be the seat of the soul by Rene Descartes. And so she was really asking me whether her pineal cysts were a cause of her headaches. So I thought that was pretty clever. And so, other than the frontal headache, she had a history of migraines since she was a teen. But these headaches were quite different. They were in between her eyes and not on just one side like her migraines. She also had some other non-specific symptoms, which many people with pineal cysts will have. She had some occasional double vision. She had light and sound sensitivity. So when her roommates would turn on the TV, it would always be too loud. She also had some vertigo. She had some, the room would spin occasionally. So not always, but she did have some other, symptoms that were, more minor, like some numbness in her hands and hands and legs. So um, so she had seen multiple headache specialists and neurologists, and finally a neurologist did order a MRI of the brain, and I'm going to show this to you a little bit closer. Um, Here we go. So here was the MRI, and you can see where the pineal cyst is there. And it's a fairly large cyst, and it looks like it's maybe pushing on the brainstem there. There's a little bit of a mass effect there that we can see. And so she got this MRI, and she came to me for a consultation. So, before I went going to sort of what I told her and the management, let's just back up and do pineal cyst sort of 101, right? So where's the pineal gland located? Well, I just showed you where the cyst was. So you can see here, the yellow is the pineal gland. And as I mentioned to you, the pineal gland sits on top of the cerebellum there, which is noted as C, and behind the brainstem, which is noted as B. And just, for sort of com completeness, there's a small channel that that takes that takes cerebrospinal fluid from the ventricle and into the spinal, around the spinal cord. And that's called a cerebral aqueduct. So it takes fluid from the third ventricle that's seen right here, and then it gets it down into where it bathes your spinal cord, and that's called spinal fluid. And so that aqueduct can actually be compressed, and I'll show you an MRI, and that can cause fluid buildup because of a pineal cyst. So what does a pineal gland do? Well, the main thing it does is it receives and conveys information on day and night cycles. And so any gland produces something, and the pineal gland produces melatonin. As you know, melatonin is secreted at night and helps you go to sleep. So it is part of what manages your circadian rhythm. Now, pineal cysts are benign, so they don't turn into cancer. So that's great news. Is say they don't progress into cancer, anything of that sort. Majority of them are actually incidental. So you just find them out by chance. Some patients get a head CT because they have a headache, or they are in a minor motor vehicle accident, so they get an MRI or CT, and the cyst is found. So So usually they don't cause any problems or symptoms, but some of them can, and for patients that they do cause symptoms, they can be quite debilitating. Well, what causes pineal gland cysts? We don't really know. Some people think it could be some hormonal changes uh, because they mostly are seen in young women, and they tend to increase and decrease in size with age, and that could be related to the hormonal cycles of women as they hit puberty and as they age. So that's one of the hypotheses. One other note, cysts that are smaller than 1 centimeters rarely cause problems. I've had a couple of cysts that were smaller than that I thought were symptomatic, but as a general rule, the cyst usually has to be about a centimeter or larger before it causes symptoms. Now, I'm going to be talking about the classic symptoms now of pineal cysts, and there's two really classic symptoms, but they're classic, but they're rare. So um, the two of them, the two symptoms are one are hydrocephalus, which is fluid buildup in the brain, and what happens is that cerebral aqueduct I talked to you about gets compressed, and so the fluid from the ventricles doesn't come down. So there's fluid buildup in the brain, and that's hydrocephalus, and you present with nausea, vomiting, severe head pressure, and that's very serious condition. It can even be life-threatening. The other way patients present is that they're not able to move their eye upward, so they have upward gaze palsy. They cannot do that, and that's called Parinod syndrome, and that's because the actual cyst is pushing on something called the superior colliculus, which is in the back of the brainstem. So those are the classic but rare symptoms of pineal cysts. Most patients don't have those severe symptoms. What they do have are headaches. They are mostly frontal, but they can be anywhere. They have some subtle visual complaints. Some of them can even have double vision. Okay, and then people tend to also have weird symptoms or non-specific symptoms that many neurosurgeons, neurologists, they may not believe that they're coming from pineal cysts, but in my experience, when you put it all together, I do believe that they come from the pineal cysts. And they can be fatigue, vertigo, nausea, syncope. A whole slew of symptoms can be related to symptomatic pineal cysts. Okay, so what do we do about them, right? So treatment absolutely has to be personalized, has to be individualized. Other things like migraine headaches, other sort of hormonal changes, other tumors, they absolutely have to be excluded by a team of doctors that include neurologists and primary care physicians. So if we deem that the symptoms are coming from a pineal cyst, then surgery may be recommended. Headaches typically that come from pineal cysts are not really touched by migraine and other medications. So say we do have a symptomatic pineal cyst, how do we treat it surgically? So surgery really has two main corridors to go through. One is an infratentorial approach where you go up from the cerebellum and onto the cyst and remove the cyst. The other corridor is called the occipital transtentorial corridor or surgical approach, which is shown here. And that corridor comes from above, kind of looking down at the cyst. And so why do surgeons recommend one or the other? Well, can be cyst configuration in some cases, but a lot of times it actually ends up being surgeon preference. And your surgeon can sort of best tell you which approach that they want to use and why. Now, once we're talking about, once we get in there at surgery, what do you see? Typically what we see is a cyst that looks greenish. It's filled with fluid, and I have a picture here. I'll show a little bit better zoomed view here. So this is how the cyst looks like. It's greenish, and there's some normal veins that are around in this area that you have to be very careful of. So once we get in there and we look at the cyst, we get into it with a fine blade usually. So we fenestrate the cyst, we open it up, we drain all the fluid, and then what I typically like to do is to dissect the cyst wall sort of circumferentially and remove the cyst using special microinstruments and an ultrasonic aspirator. And so we try to remove as much of the cyst wall as we can safely. If we leave a lot of the wall, then these cysts do tend to recur. But if you remove majority of the wall or all of the wall, then the recurrence risk is a lot less. Now, let's talk about the complications that you can have with these cysts. So with the surgery for the pineal cysts, common complications. Thankfully, all the complications are rare, so none of them are common. In experienced hands, the complication rate is relatively low, but the general complications are bleeding, and typically from veins. There are veins like the vein of Galen. They're in that area. You have to be very careful in making sure you don't injure those. Stroke, again, you can have venous strokes as well as arterial strokes. There's some big arteries and veins, again, in that area that you have to be very careful about. Cerebrospinal fluid leak, especially for the infratentorial approach above the cerebellum, that's a risk. Infection, and then in a minority of patients do develop fluid buildup or hydrocephalus after surgery, and so that's something to talk to your neurosurgeon about. Now, what about the surgical results, right? So the patient that I've told you about, and many of my patients have done very well. They typically leave the hospital after 1 to 2 nights. Many times I like to go through the occipital transtentorial approach, and many of my patients have had excellent relief, not only from their headaches, but also from their non-headache, non-specific symptoms. Studies have shown that in well-selected patients, 80% of patients can have significant improvement, and about 40 to 50% of patients have been seen or have been reported to have complete relief of their headaches and many of their non-specific symptoms. So that's a brief overview of pineal cysts and some of my experience taking care of patients with pineal cysts. Thank you for joining me for this brief webinar. If you have any further questions, please feel free to reach out to me through any of the social media outlets or my phone number that I've listed here.